Motor unit potentials, or MUPs. Voluntary activity of muscles is assessed during 3 stages of contraction: mild, moderate, and maximal full contraction. With mild contraction, only a few MUPs are observed, usually firing at 4 to 5 Hz. Not all MUPs are adequate for the needle EMG study. Near-field MUPs are adequate for the analysis of various parameters of MUPs. Genuine near-field MUPs can be recognized by a sharp, crisp sound and have a short rise time, usually less than 500 microseconds. On the other hand, the distant MUPs produce a characteristic dull sound and have a longer duration with a slower rise time, usually greater than 500 microseconds. As a general rule in the routine EMG study, we recommend analysis of at least 10 MUPs in one muscle by measurement of the shortest and longest duration, as well as the smallest and highest amplitude of MUPs. Visual scanning of 10 MUPs in one muscle is not difficult and can be achieved in a short time. Normal MUPs. Normal MUPs are different among different age groups. The duration and amplitude of MUPs increase with age. In general, the duration of MUPs in all muscles increases by 60% from birth to the 8th decade of life. The amplitude of MUPs increases by 33% between ages 3 months and 20 years. The duration of MUPs in normal individuals varies depending on which muscle is tested and on the innervation ratio. In general, smaller muscles have a shorter MUP duration than larger muscles. For adults, the duration of normal MUPs ranges from 6 to 16 milliseconds and the amplitude from 0.5 millivolts to 5.0 millivolts. With a concentric needle compared with a monopolar needle, the duration is somewhat shorter and the amplitude smaller. Polyphasic MUPs with 5 or more phases make up less than 20% of MUPs. Watch and listen to normal MUPs. Abnormal MUPs. High amplitude, long duration, or HALD MUPs. Long duration MUPs are the EMG hallmarks of chronic denervation. Long duration MUPs refers to MUPs with a duration longer than the normal upper limit. In adult limb muscles, MUPs of longer than 16 milliseconds are considered to be long in duration. Long duration MUPs are commonly also high in amplitude, 5 millivolts, and fire at a faster rate, greater than 15 Hz, with minimal voluntary contraction, but they are poor in recruitment. Polyphasic MUPs are also high in amplitude and long in duration in chronic denervation. In practice, the presence of high amplitude MUPs, giant MUPs greater than 5 millivolts, has become an extremely useful EMG marker for chronic denervation because it is usually associated with long duration MUPs. Thus, high amplitude, long duration, or HALD MUPs are typically observed in chronic denervation and are indicative of denervation process. Long duration MUPs are due to the enlargement of the motor unit territory due to reinnervation of denervated muscles. Thus, it takes at least several months before long duration MUPs become obvious in the needle EMG after nerve injury. Watch and listen to high amplitude, long duration MUPs, high amplitude MUPs, and long duration MUPs. SACID, small amplitude, short duration MUPs. Short duration MUPs are the EMG hallmarks of myopathy. Short duration MUPs refer to MUPs with a duration below the normal lower limit. In adult limb muscles, MUPs of less than 6 milliseconds are considered to be short in duration. Short duration MUPs are usually also low in amplitude, less than 500 microvolts, and recruited early with minimal voluntary contraction of muscles. Thus, small amplitude, short duration, SACID MUPs are typically observed in myopathy. In myopathy, the polyphasic MUPs are also short, less than 6 milliseconds, and small, less than 500 microvolts. These small, short, simple, and polyphasic MUPs produce extremely characteristic sounds, a sharp, rasping, scratchy sound. Once the electromyographer is familiar with the typical sound, he can recognize SACIDs easily. In myopathy, some of the fibers within a motor unit are non-functional because of muscle fiber necrosis, so that the electrode is less likely to record activity from distant fibers. Thus, the initial and terminal portions of MUPs are simply not recorded, producing short duration MUPs. It is also important to know that short duration MUPs can be seen in neuromuscular transmission disorders, myasthenia gravis, LEMS, and botulism. Watch and listen to SACID MUPs. Polyphasic MUPs. Polyphasic MUPs refers to MUPs with more than 5 phases and which have their characteristic cracking sound. When more than 20% of MUPs are polyphasic, the number is considered to be increased. Polyphasic MUPs are increased in myopathy and denervation processes. However, an increased number of polyphasic MUPs alone is of dubious significance and should thus not be regarded as a definite EMG abnormality. When increased polyphasic MUPs are associated with other abnormal EMG potentials, then they become clinically meaningful. On the other hand, the duration of polyphasic MUPs is an important EMG index of abnormality. Short duration, less than 6 milliseconds, is indicative of myopathy, and long duration, greater than 20 milliseconds, of denervation process. Short duration polyphasic MUPs are usually associated with a small amplitude, whereas long duration polyphasic MUPs generally have a high amplitude. During the reinnervation period after nerve injury, small polyphasic MUPs appear as the first sign of reinnervation. In the past, these small polyphasic MUPs were termed nascent polyphasic MUPs, but this term is not recommended at this time. Because of their small amplitude, these potentials are often mistaken for myopathic potentials. For the most part, however, these potentials have normal or long duration. Watch and listen to polyphasic MUPs and nascent polyphasic MUPs. MUPs with varying amplitude. In normal muscles, when an individual MUP fires in isolation, its amplitude, duration, and shape are relatively constant. When the amplitude of MUPs changes by more than 30%, it is termed varying amplitude. MUPs with varying amplitude are typical of neuromuscular transmission disorder. As some end plate potentials become subthreshold, some muscle fibers will fire intermittently due to blocking, and the MUPs will vary in amplitude and configuration. This phenomenon was first described in myasthenia gravis and later in limbs. While MUPs with varying amplitude are characteristic of neuromuscular transmission disorders, they can also be seen in neurogenic disorders. The best examples are reinnervation after nerve injury and rapidly progressing amyotrophic lateral sclerosis. Watch and listen to MUPs with varying amplitudes. Recruitment pattern of MUPs on contraction. In normal muscles, increasing voluntary contraction increases the firing rate of single motor unit potentials and recruits additional new motor unit potentials. The average motor unit will begin firing at a rate of about 5 Hz with a 200 millisecond inter-MUP interval. This rate will increase to 25 to 50 Hz with increased effort. With maximal contraction, the firing rate of MUPs increases further, reaching 40 to 50 Hz to form an envelope. In normal subjects, the entire screen is filled with MUPs to show a thick envelope of uniform amplitude. This is termed full or complete interference pattern. When there is a loss of MUPs in any disease process, the number of recruited MUPs is reduced, producing a gap in the envelope of MUPs. This is termed reduced interference pattern. A single MUP firing in the extreme loss of MUPs is termed a discrete pattern and shows a typical picket fence appearance. In denervation process, in order to maintain a certain force, the existing MUPs fire at an inappropriately rapid rate, rapid firing greater than 30 Hz, to compensate for the reduced number of motor units. In practice, the firing rate is assessed for a single MUP on minimal or moderate contraction. When the firing rate of a single MUP exceeds 30 Hz, then it is strongly indicative of denervation process. Classically, in all denervation disorders, the interference pattern is reduced or discrete because of the reduced recruitment of MUPs on maximal contraction. In myopathy, many MUPs are easily recruited on minimal contractions, early recruitment, and the interference pattern is normal and of low amplitude because of the excessive or early recruitment of MUPs. Thus, the classic pattern in myopathy is an early recruitment and full interference pattern with minimal or moderate recruitment. Artifacts. The most common artifact is 60 Hz artifact. The major source of 60 Hz artifacts is the electrodes themselves, usually due to poor contact with skin or electrode defect. Thus, check the electrodes and their contact first when there are 60 Hz artifacts. Watch and listen to 60 Hz artifact. The next common artifact is produced by a cardiac pacemaker, a tiny, regular artifact mimicking fibrillation or positive sharp waves during the needle EMG study. A high index of suspicion is needed to recognize this artifact. One simple question, do you have a cardiac pacemaker, will solve the problem. Artifacts from a cardiac pacemaker or spinal cord epidural stimulator are characterized by a steep positive deflection. Watch and listen to the artifact from a single and dual cardiac pacemaker. Other rare artifacts are artifacts from various stimulators placed in the patient. Again, a high index of suspicion is needed to ask a simple question, any stimulator? Watch and listen to the artifacts from the spinal cord epidural stimulator.